because it is smooth fault. And because we know that we have taken our catheter over here, over, for example, there is transfusion of great vessels, then there can be difficulty. So the character of the ventricle is very important to appreciate. And this thing, and then we of course have the left anterior oblique view, which we cannot see at this point of time. Nevertheless, we'll go to today's this thing. These are the left ones we left. So I will just open the chat also on my this thing. Yeah, now it is there. So what is this? So you have to tell what is this. Identify and give answer over here.
Answer can begin with the catheter course, the type of catheter, the chamber that is being opacified, and then any further findings. Because in your viva, it is not a spot. You have to start speaking. And for each step that you speak, there will basically your approach will be seen. You may not even miss the actual diagnosis. It doesn't matter. But at least start with the catheter course. The view, the catheter course, the chamber being opacified.
नहीं, आप जाइए 3 हफ्ते 2-3 महीने बाद 2 महीने बाद दिखाइए. हाँ, यही. हाँ, अच्छा है. So we have few answers. Okay, actually I showed this thing. So very good. Somebody has mentioned it. Catheter is in the trabeculated chamber and probably right ventricle. Yes, probably should always be used. Because you cannot be RV angiogram showing DCRV. Okay, for DCRV you have to have some sort of gradient. What all you see? Concentrate on the valve. Normally what happens is you are not able to see the, first of all you must identify the view. Which view is it? And normally you will not be able to see valve this well. And if you see carefully over here, let me concentrate if I can stop it, that valves are not opening, they are not opening. Ideally, when a normal valve opens, it should touch especially the aortic valve or for that matter the pulmonary valve, both valves. I mean, their leaflets will be touching almost the wall of the pulmonary artery or the aorta. They will be wide open. Here they are not. Let me show you if I can see. Actually, these things are, these are thin wall structures. They are not rheumatic valves. Like we saw one case earlier on of the mitral regurgitation. So they are thin. That is why this procedure is highly successful. Unless they are dysplastic. We'll discuss about that. Nevertheless, we cannot see it. So it is not LV angio, it is RV angio actually. Here the anatomical views come, what I was telling earlier on, that in this view, if your catheter is in the left ventricle, you will have almost similar kind of picture. However, there are few aspects which are to be mentioned, that our only one great vessel is getting opacified. That is the pulmonary artery, MPA, and left and right pulmonary artery. You can see the opacification. So there is no ventricular septal defect. And this is classical pulmonary stenosis. And this is, see, the valves are very well seen over here. These, in a normal pulmonary valve, if you do RV angiogram, you will not be able to see. And if you see carefully, they are not opening. Nevertheless, this is the view, another one. Here you can again see this is a lateral view of the same patient, and as we know that right ventricle is just behind the sternum anteriorly, and behind it will be the left ventricle, and here is the spine. So sternum, right ventricle, left ventricle not seen over here because there is no ventricular septal defect. because all these pulmonary stenosis cases, you have to rule out that you will have a case later on which has a multiple kind of defects. So there is no VSD, and so you see the valve. Normally you will not see this beautifully. You see the valve over here. Now this is pulmonary stenosis, and this is an incomplete diagnosis, because you cannot call it just pulmonary stenosis. You have to tell. Another important point which I didn't mention is that we have to see the infundibulum. Many patients have acquired pulmonary infundibular stenosis, which resolves in some time after opening up the pulmonary valve. Many patients will not have this, and here I don't think this fellow has this thing. So it has to be mentioned, not just pulmonary stenosis. You have to mention the site of stenosis, which will be determined obviously by the pullback by the catheter. So this is valvular pulmonary stenosis.
So if you could go back to the first.
Yeah, please, sir.
And each of their answers that they have given, we'll just tell them the mistake that they were making in the first one.
Yes, please. You take over, sir, please.
In the one just before this, the AP view that was there. So,
okay. Yes.
So what a number of students have done is they have read RAO3 over here and cranial 1, and they've said this is an RAO cranial view. So you do not consider RAO3 cranial 1 as an RAO cranial view. When we ask you the view, we expect that you are telling us based on where the catheter is, based on whether the diaphragm is visible or not. This is practically an AP view. Now, so do not just read RAO3 cranial 1 and say it is RAO cranial. A number of RAO cranial answers we have got. Secondly, a lot of you have said that this is the left ventricle. Now, sir showed you the left ventricle. So smooth it was in the when he went to last time's work, the first video he showed. So smooth, and look at this ventricle. So this is definitely not the left ventricle. So a number of answers we have. This is a left ventricle to the pulmonary artery, and I don't know what all. We have a lot of such answers. So this is classically what the right ventricle will look like. And beyond that, obviously, you look at the infundibulum, and you obviously look at these thickened valves. And beyond that, sir has already discussed. So do not see this RAO cranial and say this is an RAO cranial view. No, this is not the RAO cranial view. This tendency, our candidates also have to just read this and then classify it. RAO cranial would be something like RAO 30, cranial 30. And we do not want you to read this. We want you to look at the image and tell us what the view is. And the catheter, as sir already, the chamber, as sir already mentioned, please just look. This is the classically what the RB looks like. So do not say this is an LV angio. And then you can also.
What is this catheter? I mean, Dr. Safal, maybe we can have, because even if we spend 10 hours on this angiogram, I don't mind, because reason being, there has to be some sort of output. Because this is, I think, 37th class, and I feel that we are doing just okay, not great. So I want to do great. So what is this catheter? Nobody has mentioned about the catheter, because when you are in exam, you have to tell what is the catheter course, what is the possible catheter, what is the view, and then, as sir said, trabecular and all those kind of things. So what is the catheter? Likely catheter, possibly. Is it an end-hole catheter, non-end-hole catheter? Okay. So somebody has said Burman or NIH.
One boy said NIH. Yeah.
So I think both Burman has a balloon over here, and this is not an end-hole catheter. And you cannot inject with an end-hole catheter. We discussed earlier. It can result in staining, myocardial staining with contrast, and can result in intractable VF or VT, which may be difficult to revert. So never ever, it's a crime actually, injecting this thing.
If you look at this where only the catheter is visible, it is obvious it is not end hole. If you can just freeze that frame, sir, where just prior to the tip we can see that this is not an end hole.
Yeah, you see, maybe Dr. Safal wants to. You want me to freeze this one, right?
Yeah, they can see the lucency that is prior to the tip, just before the dye comes out.
Okay.
Yeah, there. Yes, sir. Perfect. So, yeah. So that is why it should not be an end hole, and it is not an end hole catheter.
Okay. So coming over to, this is not from the, we have to be very honest in our presentations. This is not from the same patient. This is a different patient. Let me be very clear. And this was done by Dr. Safal this is that one which you did a few days back. Okay. So what is the procedure? What is the balloon? Oh God, I think I'm messing up the situation. Okay. Quickly. BPV. Okay. Taishak balloon. Okay. Dr. Safal, you take over. You are better in these areas.
So this is clearly not a Taishak balloon. This kind of a balloon where first one end, then the other end, and then the waist. So this is classically BPV being done with in an adult being done with a BMV balloon. Yes. So this is your INA or could be Acura. You cannot make out on fluoro, but this is your BMV balloon. And so for adults where you do have your annulus of say 21, 22, and you are happy to use a 24 balloon, we do use for controlled dilatation, we do use the ENAU even in a BPP. Although classically what is described is Taishak, but please, this is not a Taishak. Taishak, the whole balloon will open up or just leaving the waist. It will not open up sequentially. This is a classic BMV balloon. So this is the classic character. This will open up, and then the waist. That is what the BMV balloon is made for. So this is BPP using a BMV.
Yes. Once it is opened well, so how long think the procedure is likely to last? I mean, restenosis rate and all that. Is it I don't want any percentage. Is it very low, or very high? Quickly. See, generally these procedures last for a lifetime, and restenosis rates are very low, provided you have achieved a good gradient. And the situation may be different when there is a condition called dysplastic valve, where the annulus is itself, not proper. How to size BMV balloon for BPV? So this is a question. So in general, you have to keep the ratio 1.2 to 1.3:1. So, I mean, let us say annulus is 18 millimeter. Typically, it will be in that range, 18 to 20 millimeter, 18, 16, 18, depending on the age of the child or adult.
So for 18, you would expect somewhere around 22. So the sizing will be the same. The size that you want at the waist will be the same that you use for a single balloon technique of BPV. And for single balloon technique, we know we lie around 1.25, somewhere between 1.2 to 3. Less than 1.2, you are more likely to have a suboptimal result. More than 1.3, there's more likely to be chances of pulmonary regurgitation. So it is the same as you're doing for a Taishak single balloon. You'll keep a ratio of 1.2, 1.25.
Okay. So this is somebody rightly said LV injection with a pigtail, and is given right to VS.
Yes, and in the previous one, it was a very good question that asked you. You will be asked to compare in the exam that I've done a BMV for a patient, I have done a BPV for a patient. Which one do I expect to come back to me for a redo procedure? So the answer obviously is I expect the BMV patient to come back to me for a redo procedure.
So all these things, because you will be asked ancillary questions also, obviously. So where is the VSD? View. So, most important thing is view. You always say that this is a LV angiogram in LO view with a pigtail catheter, and here what we can see that a smooth walled ventricle, because these are, once you have a VSD, it's a practically a congenital case. So you can have detransposition and all those kind of things. So you have to tell the ventricle characteristics also. So there is smooth walled ventricle, possibly left ventricle, and the size of VSD doesn't look to be too big. Reason being, the left ventricle is only partially opacified, and this is a. So this is a slightly tougher one. So one differential will be high muscular or perimembranous VSD. This is a high muscular VSD. Reasons are simple because this VSD, there is a gap between the, that's what I wanted to show, but perhaps this will be too much. It will be not in the LVOT. So two important questions based on this. Most common type of VSD. AR, we cannot comment. We discussed last time. Once you have a catheter through that particular chamber, then there will be some degree of regurgitation because catheter will prevent the adequate closing of the valve. Okay. So what is the most common type of VSD in general? In a child, I mean, not in a hydrops fetalis or something like that. Perimembranous VSD is the correct answer. This is the most common. And importantly, how do you size VSD? How do you define small VSD and large VSD? Because ultimately, a patient of VSD comes, you have to decide whether you need surgery or not, what you want. Compared with aortic annulus. Spelling is wrong, but it is right. Correct. You compare it with aortic annulus, and how do you do it? Okay. If this size is less than 50%, it's a small one. And if it is less than 50%, it is small VSD. If it is equal to or more than the VSD, why this you have to have a comparison, because you know you'll be seeing a child of you cannot have particular dimensions because this will be different in a small child and all those this thing. More than the size of aortic annulus is large. This answer is partially correct. More than 2/3. It is the size of annulus, and by gradient quickly. So typically, if the gradient between left ventricle and right ventricle is more than 20 millimeters large. No, this is not by millimeters. Achha, this is somebody is talking about. Then you have to mention the gradient. So it is about the cutoff is by 40 millimeter or so. That if it is gradient is more than 40 millimeter, then this is a relatively smaller VSD. However, this will be variable. But let's say somebody has gradient. No, this is 40. The cutoff is 40. So somebody is high as, let's say, this value of 64. So obviously it is a restrictive VSD. So the cutoff value is 40 for all practical purposes. So these are various types of VSD. Another case. Quickly, so that I can move forward. LV angiogram, LO view, that much I can tell you. And there is some other thing you can see over here. This is again a small perimembranous VSD. Actually, this is trying to get closed with the prolapse of the tricuspid valve, which can be seen over here. Okay. What is this? This is a ruptured sinus of Valsalva. Why do you call it ruptured sinus of Valsalva? This is not, they're not moving continuously. Okay, this is a large subaortic VSD, and in the previous views, what is important to note is that with each over here with each beat, the left ventricle is completely filling. So this is characteristically a large VSD. All these subaortic VSDs are typically large VSDs, and here both the ventricle as well as the aorta are, the aorta as well as the pulmonary artery are getting filled. So this is a classical tetralogy of failure. Now tell me, A patient was hospitalized and he developed sudden onset breathlessness and hypotension. You have to tell me everything. What is the cause of this breathlessness? What is the diagnosis? And what is the possible cause based on the picture you have available? Okay, pulmonary embolism. Okay. You have to tell me all. This is how serious is it? It's a large, how do you define pulmonary embolism? Okay, there is a filling defect. Okay. And how will you manage it? Okay, LPA. Okay, there is a lobar artery involvement. Okay, it's a big this thing. And what is the possible cause based on this thing? Based on the cynic? Can you see something else in the whole post surgery? Which surgery? Undergone surgery. Which surgery? Ortho surgery. Why? Okay. This is very good because somebody has nicely picked up these rods which have been put to stabilize the not CABG. This is not CABG. This is likely as rightly said. This is likely a spinal surgery. I mean, that's what one can say, spine surgery, and after that patient is obviously immobilized. So basically what happens is somebody has told thrombolysis. What happens is that if you have major pulmonary artery involvement and segmental pulmonary involvement, you can do lots of things. You can remove it by surgery or by catheter. However, if there is subsegmental involvement, then only medical management remains. And now the question arises, define massive pulmonary embolism, as was the case in the patient whose angiogram was shown. Well, how do you define massive pulmonary embolism? Okay, no answers. So basically, how do you define massive or submassive or okay? So it is how will you define that is 50%? So obviously, the more lung parenchyma is involved, the larger the artery involved. Okay, so somebody is saying nicely. So presence of two things, shock as well as arterial hypotension. Both if they are present, then it is called as submassive. And if patient is okay, but patient does not have hypotension or shock, but on echocardiogram you have features of right ventricular dilatation, then it is called as submassive pulmonary embolism. And once the diagnosis of pulmonary embolism is made, then risk stratification is recommended so as to define what treatment is to be done. In patients who have obviously these features, hypotension, shock, they end massive, they require some sort of therapy, either thrombolysis or catheter removal or surgery. So this is about this thing. What about the ECG pattern? What is the most common ECG abnormality? Tell me. ECG abnormality, which is most commonly seen in cases with pulmonary sinus tachycardia. Okay, very good. So sinus tachycardia is the most common abnormality. And many patients, as you see the percentages over here, all the features will be present less commonly, especially features like the one we saw it the pulmonary embolism case. There you will see all these features are right features, and the characteristic pattern which is described is S1 Q3 T3, meaning thereby that you have deep S1 in lead 2 and Q wave in lead 3. So this is important, and of course T inversion is there. S1 T3 S1 Q3 T3. So this is the described pattern. and of course you will see this thing. Now tell me, RV after load is increased or decreased? Retail-based TI, okay. RV after load increased or decreased? Typically, what happens is, once there is obstruction, you have increased pulmonary artery pressure and there is increase in after load because right ventricle cannot eject into the pulmonary artery. This may or may not result in, depending on the extent of the obstruction, RV dilatation or dysfunction, which can be very well appreciated on the echocardiogram. If it is appreciated on echocardiogram, but BP is normal, as I said, it is a submassive pulmonary embolism. RV cardiac output will be decreased, the intern to the L. So RV is a shift of the interventricular septum to the left side, as well as less output or LV preload is decreased because RV output is decreased, and ultimately there will be systemic hypoperfusion. So biomarkers are done to not only to diagnose, as is the case with D-dimer, but also to risk stratify patients who have raised troponins as well as PNP levels are typically in bad shape and require more aggressive treatment. Now, various treatments are there: anticoagulation, thrombolytic therapy, and surgical embolectomy, etc. But what about the anticoagulation? So, as soon as it is important to note that patients who have massive pulmonary embolism, like the one we saw, the doses of unfractionated heparin are larger than usual, what we do in cases of coronary cases. So most patients should receive 10,000 units of heparin, followed by a continuous intravenous infusion of about 1200 units per hour. I mean, normally we give 800 or so, and so as to target of APTT of 80 seconds. The idea is that you have to give heparin in cases where, you know, there is significant pulmonary embolism, and after that, if you have to in the cases where there is massive pulmonary embolism, and you are to where it is written, okay. So for massive and submassive pulmonary embolism, as I said over here, no shock but RV dilatation or dysfunction, that is submassive. In both the cases, you have to give thrombolysis. In cases who do not have these features, then only anticoagulation is sufficient. And it is important to note that fibrinolysis, okay, what is the preferred agent? Tell me quickly. What is the preferred FDA approved agent? And what is the dose? You people must have seen, some of you must have seen cases. L-taplase is the correct answer. And this is the only agent which has been approved by the FDA. How do you give it? Okay. So very nicely said. I am impressed that a lot of people have given the right answer. You have to know it because many people may not be knowing it. 100 milligram over 2 hours is the standard. And when you start the L-taplase, before that you have to stop the infusion, and later on once this is over, and you have to check the activated partial thromboplastin time, and if it is less than 80 seconds, you have to start the anticoagulation that is happening straight away, or you have to wait for it to go below 80, and the idea is that you have to continue intravenous heparin. That's most important. Now, most of our hospitals in India, because this costs some 40 to 50,000 rupees or so, this tissue plasminogen activator will not be available. So you can give streptokinase, urokinase, or even there are case reports. These are earlier ones that with tenecteplase, which is a little cheaper at around 15 to 20,000 rupees, this can be given as a bolus, and it has been shown to be very effective in the anecdotal case reports. So tenecteplase will be the second choice if I have to go, and regarding streptokinase, you give 2.5 lakh units bolus followed by 1 lakh or 12 to 24, much less effective. This will be more effective than replace. There are various thrombectomy devices. They are not easily available, but in general, because thrombus volume, as you saw, is very large, so most of the catheters, thrombectomy devices do rheolytic thrombectomy, meaning thereby they churn the thrombus, at the same time they suck it also. Open surgical embolectomy can be done, but has its own problem, and you require real expert surgeon, like in the case. Now we come over to the another angiogram, and you have to answer it. 3-month-old child, this is a young baby, basically young infant, presenting with congestive heart failure and mitral degradation, and the physician or the pediatric person is confused what is going on. This is a young boy, a young child, and so Al Kappa, why do you say so? Tell me all the see diagnosis. I'm not interested in diagnosis. I'm not interested in diagnosis at all. I'm interested in what you see. No, most of the conditions have multiple diagnoses, differential diagnosis. So you have to tell me what you are seeing and what you are not seeing. This is a small child actually. RC is filling the okay. RC, yes, very good. So this is what we want to see. See, right coronary artery is dilated. Dr. Safal, you want to comment on this one?
For the
Right coronary artery, yeah.
For spotters purpose, the easiest thing to see is it's a huge coronary artery given the size of the catheter. Now, the moment you see a huge right coronary artery, you trace it towards the end, you will see the left filling up, and then you will finally see the dye going into the pulmonary artery. So the first thing to suspect when you get a huge right coronary artery is Al Kappa, and then you follow this contrast through, and you can see the left, and then finally the contrast going into the pulmonary artery.
Yeah, I fully agree, because in a small child, this is likely a 4 French catheter or so, and this is the means 1.2, 1.3 or 4 millimeter, and you do not expect a child to have this large 3 millimeter coronary artery. So this is so, and you have to mention that you see huge amount of collaterals. Huge amount of collaterals. Now my question arises that why this child has presented at 3 months to our great students? Why not at birth? I mean, this is a problem which should be, this is a congenital issue. So why child should not be presenting in month? And LV dysfunction, PA pressure has decreased. Very good. So now, okay. So this is very important for, so everybody does not know. Some of our great students know. So in the neonatal or immediately after the birth, neonatal period is typically up to 1 month or so. So the RV pressures are high. So there will be antegrade flow into the left main artery, as mentioned in this schematic diagram. So at that time, of course, there will be some sort of dysfunction because it is a pulmonary blood which is going into the left main coronary artery. But later on, as the ischemia develops, so there will be collateral formation at that point of time. But there will be some dysfunction, and later on there will be full-fledged dysfunction will develop, as seen over here. And somebody will be asking you, you have to know the natural history of all the conditions, especially congenital conditions, and for that matter, acquired conditions also, like mitral stenosis. How many of them, if untreated, rheumatic will be alive at severe mitral stenosis, or for that matter, overall mitral stenosis will be alive at 10 years or so. So those kind of natural history are always asked for tetralogy of failure, VSD and all that. So 90% death rate within first year, mainly because of the dysfunction. So what is the management? What is the management as per you people of these patients? So the amendment is obviously reimplantation surgery of the L kappa is the current, ideal management, ideal option. Meaning thereby you remove the coronary artery from the pulmonary artery and reimplant into the aorta. But coronary button transfer, very good. I am impressed because it is not just the coronary artery. It is, you have to remove the adjoining wall also with it. And what happens is sometimes the anatomy is such that you do not have the length of coronary artery remaining that you can bring it to the aorta. So people, do some sort of graft or this thing, but obviously the success rate will be much lower. I mean, you have to harvest the left coronary from the pulmonary artery and reimplant it. So you need a certain length, which you can be, sometimes that is not there. So there is a procedure called Takayuchi procedure, which involves, making a tunnel sort of thing from the pulmonary artery to the aorta. And, connecting that, from that tunnel, they connect it through, it's shown over here. They have shown, it's a surgical procedure. I mean, you open the pulmonary artery, make a tunnel, do not do anything with the, do not remove the coronary artery from here. This is not a reimplantation, but opening and connecting it with the tunnel. So it is also called as intrapulmonary tunnel repair or Takayuchi technique, and which is still done in patients who have, in whom the artery cannot be harvested for implantation into. That was about the L kappa. What is this, and what will be the likely management?
So what catheter, what have we engaged? At least start with that and then tell us after engagement, what are we finding?
So you see a huge aneurysm. Yeah. You have to tell those kind of situations. Coronary AV fistula to the right ventricle. Okay, very good. Okay. So whenever you have whenever you are talking about, even if you consider your diagnosis, you have to tell coronary AV fistula from which artery. I mean, it could be left anterior descending, right coronary, or its branches, or you may not be able to tell in that much detail, but you have to tell a complete diagnosis.
And then once you are telling us to a particular ventricle, then there has to be a basis for it. That would mean that if it is right ventricle, then later on you're seeing the pulmonary artery being filled. So it's just not that there's something on the right side, so it is right ventricle. So think more. Yeah, I think others are thinking.
Yes. So this is classical. This is a coronary artery aneurysm, and as you cannot see any ventricle getting filled, so this whatever it is, it needs urgent management by patient needs a graft to the distal right coronary artery by isolating this aneurysm, by suturing it, and if possible removing it. So right coronary aneurysm is the correct answer. What are
the possible etiologies that you end up with this kind of aneurysm? Just a few differentials. Well, okay, one such huge aneurysm, Kawasaki, okay, could be a possibility, more likely of smaller and multiple aneurysms. Atherosclerosis per se only has this kind of aneurysm, unlikely. So stent infection. So when we are doing our coronary implantation, be very careful. Do not drop your stent on the ground or touch it with unsterile hands, because that stent you are implanting there. So it could be a mycotic aneurysm. Infection is one, and polymer reaction to the stent is another. So it is possible that after your stenting, if this is how some of these patients present, is that you have stented the patient, 1 month later the patient is presenting with fever, the patient is presenting with chest pain, and we have a tendency to say that, okay, fever, you go to the physician, that is not my concern. So you, somewhere at the back of mind, you have to have this possibility that if there is a high grade fever, if there's which is does not have an obvious cause, then we may need to look at the local implantation that we have also done as a cause of fever. So,
Okay. So just this is describe the what you see quickly. Don't waste time. Quickly describe what you see. You do not have to focus on what is very obvious. You have to focus at the adjoining, findings also. Overall, you have to see the picture as a whole. Okay, aortic root angio, very good. Aortic pseudoism, okay, very good. So what could have caused it? I mean, obviously, people will be interested in knowing if somebody has, it's a huge aneurysm, obviously. And pseudoism have a tendency to rupture. So this is a big issue, big problem. Aortoarthritis. Why aortoarthritis? I mean, it can result in aneurysms, but typically they are generally secular dilatations. Not this has a very narrow neck actually. If you see over here, I will call it a I'll describe all these things. So this narrow neck is important because something can be done about it. Maybe somebody can deliver a coil if there is problem with other techniques, other things are not available, but typically these things require a graft post thoracotomy. Yes, that's what I wanted to listen to. You see these sternal wires because we know that after surgery the sternum never fuses and you have to keep that in place. So patient had some sort of, and you see these markers of surgery. So this is important, post thoracotomy. So you have to mention. Now this was a case which somebody was doing, and he was wire went very easily actually across the lesion. This was for routine stenting, but balloon was not crossing actually. So what could have been the reason? I mean, this can happen to any of us, though we use this kind of catheter less often. So false passage from where? Yes, false passage to false lumen. Okay, calcium. Okay, so these are important. False lumen, calcium in front of balloon. Okay, catheter is not hooked. Okay, so these are all problems which can be there. But here, wire is subintimal. Okay, very good. See from where the wire is coming out. Now, all your answers are correct. Yes, Dr. Sabal, please, sir.
You already got a hint. We don't commonly use these catheters. Look at this.
See, these are the catheters to tell you the hint. Sometimes what happens is you have a right coronary artery which is very important. Left is markedly diseased, and the moment you put it, and the catheter is getting, it is ventriculizing. So patient goes into hypertension. So you want that while you're doing the procedure, your perfusion should be, well maintained through a hole. That is a hole which is not end hole, but just near to the end hole, so that perfusion is maintained. So here, what you see over here is that wire is coming not from the end hole, but to the side hole. And that is why, which is much smaller in diameter compared to the end hole. That is why nothing is, all you need to take out this wire and reinsert the wire through the end hole. So this is important. Okay. So the causes which you listed are all okay and can be caused that your balloon is not going while your wire has gone. So what is the diagnosis?
While we are at that catheter, I'll just ask you one advantage and one disadvantage of using this kind of a catheter, which sir has shown you. A catheter with side, a JR with side holes. Advantage, I think sir has already told you. Some amount of perfusion is maintained where the, and a disadvantage, otherwise we would be using it every time. We don't use it commonly, so there must be some disadvantage also.
It appears that most of them not heard of this kind of catheter or seen it. Looks like.
No, not less support. The disadvantage is that it gives you a false sense of security. Even when your tip is actually wedged, it may show you good pressures. And if you carelessly inject there, your whole artery will get dissected. So the wedging is not clearly manifested on the pressure waveform. It may falsely show you a normal pressure waveform. Okay, sir.
Yeah, so very nicely said. Never, 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 never inject, as Dr. Safal so nicely said, in a wedge position. Otherwise, you will end up in very, very severe trouble and even death on table. Okay, intracorneal is not reliable. Very good. Somebody answered it in any case. A little late, but answered it anyway. So, quickly, perforation, where, vessel. I'm not interested in perforation. I want complete this thing. This is a left ventricular angiogram. What is this thing? And perforation. I know this is a perforation. Where, what kind of perforation? Massive one, grade 1, 2, 3. Tell me everything quickly. Perforation of the mid left anterior descending coronary artery, grade 3 perforation, because it is. So you have to mention everything. This you don't have to take 1,000 years to answer it. Covered stent, maybe the what will the first step you will go? Managed by a covered stent. Okay, covered stent. Of course, you can put anywhere in the artery. But I'm not, because covered stents have a very, very high restenosis rate. So it is best to avoid them. Balloon tamponade, very good. So balloon is already there. Balloon tamponade was done. And this is, if you see carefully, I agree, this is not very well seen. This is post-stenting. And just to reiterate the fact which was stated earlier on many times by other speakers and myself also in one of the talks on coronary perforation, is the fact that by some grace of God, if the coronary perforations even this large occur after post and dilatation, that many of them, not all, but many of them resolve by just reversing the anticoagulation with protamine and just conservative management. So you may avoid a stent graft. Stent graft can always be done. Okay, so balloon tamponade should be given for some time, keeping a watch on ischemia and its related problems. Okay, so that was about it. So this is another one. Quickly, so this was a fellow who was complaining of lot of dyspnea, lot of chest pain, lot of symptoms, and pericardial calcification, very good. So we see lot of pericardial calcification, and you see it, or you call it, is not because of dye, because many a times if there is extravasation, that is, there is some sort of leak from the coronary, you will again see this kind of thing. So this can be seen even before injection is being done. So this is pericardial calcification. So this is a case of constricting pericardial. Why angiogram is what angiogram is showing? Look at the artery movement, and so if you see that because AV groove is practically there is a lot of calcification, so there is very little movement. So coronary artery over here is moving very well, but it is encased the coronary in the calcium. So there is very less movement. So the constrictive pericarditis with encased coronary artery. So coming over to this one, I got this one, so I thought maybe we'll get it. What is the diagnosis? As a hint, count the number of beats. What happens when? Quickly, ASD, very good, ASD. So it is ASD. So this typically, this opacification is occurring at 4 to 5 beats. If it is occurring more than 3 beats, it means that the blood has had time to go to the pulmonary circulation and come back and opacify the ventricle. Further, if you see carefully, then your pulmonary artery over here, pulmonary veins, they are also getting highly opacified. Plus, if our ASD with this kind of opacification, there are two things are clear. Whatever it is there, it is large. If it is pulmonary fistula, it is large. If it is ASD, it is large. If it is VSD, it is large because the atria are filling first. So VSD and PDA are practically ruled out. So this is either pulmonary fistula because it is after this thing. So pulmonary fistula is the correct answer. So what is the treatment of choice? Embolization, but many patients will require surgery, but many patients may still be untreatable. And reason being that there are so many of them. There are hundreds of AV fistulas sometimes. Nevertheless, so tell me the diagnosis. We have had a talk on OCT many times. This is a run which I cannot stop. It's a continuous run. Think about it, how it is done. From proximal to distal or distal to proximal? Tell me quickly. Thrombus, very good. And where is the thrombus? I think we'll have to repeat that lecture. Okay, great. So what we see is we have a smaller lumen at the start of the this thing, and lumen gradually becomes bigger, and then there is a dissection, and then we see the stent struts. So this is a post-stent dissection. Is it significant or not? Will you leave it or do something about it? Put in another stent quickly. It's a add dissection. Very good. Nice is a leave. Why leave? Why not do it? What is the criteria for significant dissection? Don't want full criteria, little bit. Somebody said don't do anything about it. See, no, there is no thrombus. There is nothing intraluminal actually.
How many degrees? What length? Tell us
Yes.
something.
So there is a criteria. So we have been, I have myself told you these criteria earlier on. You may not tell them word by word. I agree there is a lot to learn, lot to do. So, but at least some this thing. See, in general, I wish I could stop this one. In general, if your dissection is entering into the media, as this is the media, this thin line is media. So it is going much beyond the media and it crosses more than one quadrant. I mean, it is more than 60 to 90 degrees and over a significant amount of length, more than 3, 4, 5 millimeter, which is there based on, because it is persisting for a long time. I think I cannot stop it actually. So this requires stenting. So this is very important. It's a significant one. It is going, see this in media, if you can appreciate it. Change it. Okay. Oh God. I mean, tell me, this is the answer which somebody gave in one of the earlier angiograms, when we were showing VST. Which view and what you see in this view? Which cusp? Okay, RO view. Very good. Excellent. So you tell properly, this is a autogram done in the right anti-oblique view with a pigtail catheter. That is how you describe it. So this is a ruptured sinus of Valsalva from which sinus? Which sinus? I think this is one of our last ones. Maybe we'll continue later on. This is likely the right coronary sinus. And how do these patients present? Typically, acutely, or they present as a case with some sort of dyspnea for lasting for maybe 2 years, 3 years, something like that. Presentation. in general. So they generally present as a acute chest pain, acute heart failure. Very good, I am impressed. Acute or subacute presentation which requires immediate management, and you find a continuous murmur as written on the left hand side on the mid or lower left sternal border. And typically they can be well managed with a device closure, typically with a PDA device. And this will be the last one. Dr. Safal, this, with your permission, this is the last one because I cannot speak any further.
Absolutely. Absolutely.
See both of them. Take your time. Dr. Safal, maybe you can handle this one. So first describe IAA. What is IAA? MEPCA. Okay. Where is the MEPCA? See, for MEPCA, you can take this and this shot also, because MEPCAs are notorious to arise from anywhere, even from coronary arteries, from subclavian artery, from so many places. But for MEPCA, you have to have some sort of other congenital heart defect, which is typically, there should be decreased pulmonary perfusion so that MEPCAs have a reason to develop. Okay. So here, if you see aortogram, you see coronary arteries, and here you see with this same catheter has been pulled back, and you see the pulmonary artery is also filling. And beside that, you see that there is some sort of narrowing beyond this subclavian artery. This is subclavian artery. Not very well seen, agreed, but this is subclavian artery, last branch left from the left side. So you have a coarctation over here. You have some sort of maybe PDA which is not very well seen. Catheter should be kept over here to see. Nevertheless, see the pulmonary artery, how beautifully they are seen. Those are large PDA also. And if you see carefully, I told you maybe 100 times that normal valves they do not give any impression, any shadowing, because they are so thin. What do you see over here? You see beautifully, and I told you another thing, that normal valve, especially for this holds true, especially for aortic and pulmonary valve, they will touch the wall of the pulmonary artery. I mean, it will be something like somebody is entering in a really violent fashion through a door, slamming the door, and then the doors automatically get shut. It is something of that sort. So here the valves, aortic valves, you see carefully, there is some sort of lucency, and they are not getting shut, not getting open very well. This, if you see carefully, you have to have eyes to see it, nevertheless. So this is the case where you have coarctation, you have valvular aortic stenosis, so a patent ductus arteriosus. So it is like this. So with that, we have lots of other spotters which will be considered later on. My request to our students is that